Welcome to the Surgical Edge podcast for surgical insights, reviews, discussions, and to stay updated. Let's dive in.
What if the surgery your patient is, practically begging for?
The one they've been counting down the days to.
Right. What if that is the exact procedure that's going to completely ruin their life? Welcome to the deep dive.
It's a heavy question, but it's one we have to ask.
It really is. Today we're talking about stoma reversals. It's an elective procedure where success isn't just about perfectly healed anatomy.
No, not at all. It's about navigating a massive psychosocial and, frankly, physiological minefield.
Exactly. We're speaking directly to you today, the surgeons, the medical professionals, and the residents who are looking to refine your approach to patient care.
Our mission today is to unpack the clinical protocols for stoma reversal and bowel restoration.
Yeah, moving past those basic textbook definitions and really looking at the critical nuances of when, why, and how we actually get these patients back to normal continuity safely.
Because it's a topic that demands a profound shift in surgical philosophy. I mean, your index operation, the resection, the diversion, that was likely life-saving. But the reversal, that is almost entirely about quality of life.
Yeah, and as you hinted at, a technically flawless anastomosis doesn't mean anything if the patient ends up functionally miserable.
Absolutely.
Now, before we begin, a quick reminder that this content is for reference only. You should always follow local guidelines in your clinical practice.
Always a good reminder.
All right, so we've got a stack of clinical protocols and guidelines regarding bowel restoration in front of us. And the baseline rule here is that the primary indication for a reversal is that the stoma was explicitly intended to be temporary.
Right, like the classic scenario of a diverting loop ileostomy post-LAR to protect a low anastomosis.
Or, a temporary colostomy formed during active pelvic sepsis. The underlying disease or the acute inflammation has to be completely resolved.
It does. But let's dig into the biology of that waiting period for a second. We tell patients they have to wait, but what's actually happening at the tissue level while that bowel is diverted?
Well, it's funny. Having a stoma is like setting up a massive traffic detour on a highway. You only reopen the main road when the bridge is, 100% rebuilt and safe to drive on.
I love that analogy because you're dealing with two distinct, often opposing biological processes here.
Okay, how so?
Well, on one hand, you're waiting for the acute inflammatory cascade in the pelvis to just burn out. You need the collagen deposition at the primary anastomosis to mature and cross-link.
Which is what gives it tensile strength, right?
Exactly. But simultaneously, the distal diverted bowel is undergoing atrophic changes.
Because it's not being used.
Right. Without the fecal stream, specifically without the short-chain fatty acids like butyrate that the colonocytes rely on for energy, you see mucosal atrophy. You get diversion colitis.
Yeah, the mucosa basically starves. And we see that clinically when we scope them, right? That classic erythema, the friability.
Sometimes even exudate in a bypass segment, yeah.
It always makes you pause and wonder if you're looking at a subclinical leak or just, severe diversion colitis.
And it's a critical differential to make. Because if you reverse a stoma into a severely atrophied, inflamed distal segment without properly assessing it,
We're asking for trouble.
you really are. You're exposing a weakened, non-compliant rectal reservoir to a sudden influx of stool.
Wow.
That's a massive setup for severe urgency, frequency, and functional failure, even if the staple line holds perfectly.
So we know the physiological stakes here. But let's talk about the driving force behind getting them back to the OR.
Okay.
In your experience reviewing these cases, how much of the push for reversal is usually driven by the surgeon wanting to, finish the job versus the sheer psychosocial burden the patient is carrying?
Oh, it is heavily weighted toward the patient's burden. Living with a stoma comes with a tremendous grinding cost.
Yeah, physical and mental.
Absolutely. We see chronic dehydration, stomal prolapse, peristomal hernias, severe peristomal dermatitis.
And the psychological toll of that altered body image has to be massive.
It is. Patients view that bag as a daily reminder of their disease. They want it gone. But here is the hardest reality we face in clinic.
What's that?
A significant percentage of those quote-unquote temporary stomas quietly become permanent.
Wait, really? Just because the physiological debt of the first surgery was too high?
Often, yes. A stoma planned as temporary stays permanent because they develop a recurrent malignancy, or maybe they have a chronic, low-grade anastomotic sinus that just refuses to close.
Oh, wow.
Or quite frequently, their overall frailty and advancing comorbidities mean the cardiovascular risk of a second major elective surgery is just unacceptable.
Which means desire doesn't equal safety.
Exactly.
And to prove it's safe to proceed, we're heavily reliant on a ghost, basically. The previous surgeon's operative note.
Yes, the historical blueprint.
Right. The protocols emphasize intimately understanding the index operation. You pull the op note, the pathology, the post-op imaging. You need to know if the distal anastomosis was stapled or hand-sewn, what the blood supply looked like.
All of that is crucial.
But I have to push back here. Let's unpack this and be real for a second. What if the original surgery was done at a completely different hospital 3 years ago?
Oh, I know where you're going with this.
I mean, half the time an op note from an outside hospital just says, colon mobilized, stapler fired, no leaks. How much detective work is really required here when the blueprint is practically useless?
It's a terrifyingly common scenario. When the op note reads like a haiku, you have to approach the reversal not as a standard procedure, but as an archaeological excavation.
That sounds intense.
It is. You're going in assuming the worst. This is especially true for a Hartmann's reversal.
Because the anatomy is notoriously difficult.
Exactly. If you don't know exactly where that rectal stump was left, or if it wasn't tagged with a Prolene suture, you're dissecting through a concrete block of dense, fibrous pelvic scar tissue.
Just trying to find a tiny piece of bowel.
Right. You're trying to distinguish critical anatomical artifacts like the ureters or the iliac vessels from sheer scar without causing a catastrophic iatrogenic injury.
So if the operative note is thin, your clinical exam basically becomes your only reliable baseline.
Absolutely.
And the guidelines mandate a rigorous physical assessment, specifically highlighting the digital rectal exam. But for an audience of surgeons, we all know what a DRE is.
Right. It's basic stuff.
But what I want to know is, in the context of a diverted pelvis, what specific tactile feedback are we looking for that might actually change our operative plan?
Well, you aren't just checking basic tone. You're feeling for subtle fibrotic rings at the anastomosis that indicate a prior subclinical leak that healed by secondary intention.
Oh, interesting.
Yeah. If you feel a dense stricture that won't easily admit your finger, you already know you might be looking at a situation where you need to dilate under anesthesia.
Or worse, right?
Or worse, resect and redo the anastomosis entirely. You're also assessing the squeeze pressure to gauge if the sphincter complex can even handle the restoration of continuity.
Because if their resting tone is non-existent...
You're having a very different conversation with that patient.
That's a great point. So the clinical exam gives us the tactile reality, but we still need objective imaging to prove the integrity of that distal segment.
We do. We need to stress test the current state of the internal plumbing.
Right, and the gold standard pre-reversal test we see in all these protocols is the water-soluble contrast enema, which is basically a stress test for the plumbing before we turn the main water line back on.
That's exactly what it is.
But let's get into the weeds on this. If the water-soluble enema comes back perfectly normal, are we completely in the clear?
Not at all. A normal study is reassuring because the test has a strong negative predictive value. But the false negative rate in ultra-low pelvic anastomoses can absolutely bite you.
Why is that?
Well, if the anastomosis is only a few centimeters from the anal verge, the pooling of the contrast, or the balloon of the catheter itself, can easily obscure a posterior microleak.
Oh, I see.
Yeah. Or it can hide a tiny tortuous sinus tract.
So you're blind to the most high-risk area, which is exactly why the guidelines suggest endoscopic assessment, like a flexible sigmoidoscopy or a proctoscopy.
Precisely. The enema shows you the macroscopic structural outline, but the scope shows you the microscopic mucosal health.
You're going in to directly inspect the staple line.
You are. You're looking for low-grade ischemia that didn't result in a full blowout but left the tissue pale and friable.
Right.
You're looking for retained staples causing localized inflammation. You can spot that pinhole sinus that didn't fill with contrast simply because it was plugged with mucus.
Now, looking at the varying guidelines across different institutions, there's always a debate about CT scans.
Oh, the CT debate, yes.
If we want to be incredibly thorough and we really want to avoid catastrophic complications, why not just do a CT scan and a full colonoscopy on every single patient before reversal?
It's tempting to want perfect information, I get it, but we have to balance yield against resource allocation and radiation exposure.
Okay, that makes sense.
Routine CT scanning for a simple loop ileostomy reversal in a patient with a pristine post-operative course offers a very low diagnostic yield. You reserve the CT for specific high-stakes questions.
Like suspecting an occult pelvic collection.
Exactly.
Yeah.
If the patient had a rocky recovery, unexplained fevers, or a prolonged ileus after the index operation, You need cross-sectional imaging to ensure there isn't a smoldering, thick-walled abscess sitting right next to your anastomosis.
Yeah, that would be a disaster.
It would be. It's also vital for oncologic surveillance if they're due. And for a post-Hartmann's pelvis, as we discussed, the CT is your only way to map the spatial relationship of the diverted stump to the surrounding viscera before you start your dissection.
Right.
But if you see a persistent symptomatic cavity or an unhealed sinus on that scan, that's a hard stop. You don't reverse them.
You just cancel the surgery.
You have to. Forcing fecal traffic across an unhealed defect is a guaranteed ticket to systemic sepsis.
You're just setting them up for a catastrophic failure and a much worse stoma later.
Exactly.
So let's say the local anatomy checks out.
Yeah.
The enema is clear, the scope shows healthy mucosa, no collections on CT. We have to zoom out from the pelvis and look at the patient's systemic physiology.
Yes, we need to look at the whole patient.
We're talking about the holistic pre-op workup. The protocols list the standard labs, CBC renal function, LFTs, inflammatory markers, but I want to talk about the physiological mechanisms behind why certain comorbidities completely derail an anastomosis.
Okay, let's get into it.
Let's look at diabetes and obesity or smoking and malnutrition. We all know they're bad, but what's actually happening at the cellular level that makes a surgeon delay a reversal?
It really comes down to microvascular perfusion and collagen synthesis.
Okay.
With smoking, the nicotine causes potent vasoconstriction, but the carbon monoxide also shifts the oxygen dissociation curve.
Meaning the tissue at your staple line is literally suffocating.
Exactly. And with poorly controlled diabetes, say an HbA1c of 8.5% or higher, you have a systemic accumulation of advanced glycation end products.
And what do those do?
These actively impair leukocyte function, meaning the patient can't fight off local bacterial translocation, and they disrupt the cross-linking of collagen fibers. The tissue might look okay in the OR, but it simply lacks the biological building blocks to heal.
It's a structural failure waiting to happen because the underlying cellular machinery is broken.
Precisely.
Now, here's an area I find incredibly fascinating in the preoperative workup from the sources. High-output ileostomies.
Oh, yes.
We see these patients in clinic, and the assumption is often just, they need some IV fluids.
Right.
But how often does a purely physiological issue, like severe dehydration or low magnesium from a high-output stoma, end up delaying a structural surgery like this?
It happens all the time. This is a classic trap for the unwary surgeon. A high-output stoma isn't just a volume problem. It's a profound intracellular depletion problem.
Because they're losing so much more than water.
Right. These patients are losing massive amounts of sodium, which throws their renin-angiotensin-aldosterone system into overdrive.
Yeah.
But more critically, they are dumping magnesium and potassium.
And chronic hypomagnesemia is notoriously difficult to correct quickly, isn't it?
It is, and it makes them incredibly dangerous to anesthetize.
Wait, why is that?
Severe hypokalemia and hypomagnesemia lower the resting membrane potential of the myocardium. When the anesthesiologist pushes induction agents, that patient is at a significantly elevated risk for life-threatening ventricular arrhythmias.
That is terrifying.
It is. Furthermore, low magnesium actively prolongs paralytic agents. So you might finish your beautiful, technically perfect bowel anastomosis, but the patient can't be extubated.
Because the paralytics won't wear off.
Exactly. Or they develop a profound, week-long post-operative ileus because their smooth muscle is electrically stunned.
That's a perfect example of why this isn't just a technical exercise in plumbing. You have to aggressively optimize their fluid balance and electrolyte stores weeks before they even sniff the operating room.
You really do.
Which brings us to the ultimate surgical dilemma. Timing and patient selection.
The hardest part.
Right. We've optimized the physiology. We know the anatomy is intact.
Yep.
When do we actually pull the trigger and do the pragmatic checklist?
Timing is notoriously slippery. In a textbook scenario for a temporary loop ileostomy, you might aim for reversal around 8 to 12 weeks post-op.
Once the collagen has matured and the acute adhesions have softened.
Exactly. But clinical reality rarely follows the textbook.
Right, because adjuvant chemotherapy throws a massive wrench in that timeline.
Completely. You cannot perform an elective bowel anastomosis on a patient whose immune system is actively suppressed by systemic chemotherapy. Their healing capacity is near zero.
So they just wait.
So they wait. And for a Hartmann's reversal, the timeline stretches even further. You're often waiting 6 months to a year.
Because of the pelvic dissection and adhesions?
Yes. You need that dense, wood-like pelvic inflammation to mature into sheer dissectable planes. Going in too early on a Hartman's is how you end up with massive hemorrhage or an injured ureter.
Okay, so let's talk about the hardest clinical question you can face regarding selection.
Sure.
You have a patient who desperately wants their stoma gone. It's ruining their marriage, they can't work, they're begging for a reversal.
Oh, I've seen it many times.
But when you examine them, perhaps they had an ultra-low resection, their sphincter function is terrible, and their anal manometry shows barely any squeeze pressure. How do you counsel someone when the reversal might actually make their quality of life worse due to incontinence?
That is the true art of surgery, and it requires absolute, unflinching honesty. You have to sit down with them and redefine what success looks like.
How do you even phrase that?
You explain that reversing the stoma means trading a discrete, manageable bag on their abdomen for being tethered to a toilet 20 times a day, dealing with clustered bowel movements, urgency, and the constant fear of public soiling.
Wow.
You have to clearly articulate that severe low anterior resection syndrome, or LARS, is a far worse quality of life than a well-managed stoma.
You essentially have to save them from their own expectations.
You do. You have to firmly counsel against the reversal. And it's not just about unacceptable continence. You apply that same firmness to the frail, elderly patient whose cardiopulmonary risk is astronomically high.
Or the patient with persistent leaks or recurrent malignancy.
Exactly. You have to continually reinforce that this is an elective procedure. If the functional outcome is going to be disastrous or the operative risk is too high, the safest, most compassionate surgical decision is to leave the stoma alone.
So instead of rattling off a standard checklist, let's synthesize everything we've unpacked today into a core surgical philosophy for stoma reversals. It seems to boil down to 3 pillars: prove the anatomy, optimize the physiology, and secure the function.
That's exactly it. First, confirm the indication and prove the anatomy. Don't trust the old op note blindly. Examine the patient, do a DRE, assess distal integrity with a scope and enema, and use selective CT scans.
And second, optimize the physiology.
Right. Correct the cellular deficits, whether it's intracellular magnesium from a high-output stoma or checking their fitness and hemoglobin A1C before you ever book the OR.
And third, secure the function.
Because a healed anastomosis is useless if the sphincter complex can't handle the load. Make sure the patient's postoperative reality will actually be an improvement.
That's a fantastic framework to keep in mind. Before we wrap up, I want to leave you with a final, somewhat provocative thought to mull over as you head back to your wards or clinics.
I love this part.
Think about the patients on your current roster whose quote-unquote temporary stomas have quietly, almost invisibly, slipped into becoming permanent over the last few years.
We all have them.
Are there subtle ways their comorbidities could be better optimized right now to safely get them back to the OR? Or is the deeper, much harder work actually about sitting down with them, abandoning the false hope of reversal, and helping them psychologically accept the stoma long-term?
It's a remarkably fine line between relentless surgical optimism and pragmatic, compassionate acceptance.
It really is. It challenges us to be physicians first and technicians second. Well, if you like this content, please do not forget to share it with at least one of your colleagues or friends to help spread the word. Also, be sure to check out our YouTube and other social media pages. And if you want more insights, do check our previous season and episodes, which feature some very relevant topics for your clinical practice.
There's some great stuff in the archives.
There is. Thank you for joining us on this deep dive. Remember, closing that diversion requires just as much strategic foresight as creating it in the first place. Take care.
Thank you for listening to the Surgical Edge podcast. Don't forget to like, share, and subscribe. Help us grow and deliver even more relevant surgical content by pressing the support button. Your contribution truly makes a difference. And don't forget to share with us your advice, feedback, and the topics you would like us to include.